Well, good morning, ladies and gentlemen. It's my very great pleasure to welcome you to this meeting to look at some of the very exciting results which have recently become available from the Garfield AF registry. And I'm AJ Kakar from London, Director of the Thrombosis Research Institute, and we have the pleasure of sponsoring this registry through an unrestricted grant from Bayer Pharma. And I'm joined by my fellow steering committee members here, three very distinguished colleagues, Professor John Cam from London, Professor Keith Fox from Edinburgh, and Professor Jean-Pierre Basson from France. And they are going to present different aspects of data from the Garfield registry. And after that, we will have a question and answer session where we hope that you'll be able to put some interesting questions to my colleagues. Now, what I'd like to do at the outset is to give you some background to the registry and to bring you up to date on the global status of this program. The program was initiated at the end of 2009 and is currently the largest prospective registry looking at newly diagnosed and presenting AF patients in some 35 countries in over 1,000 care settings. And the care settings determined on the advice of the 35 national coordinators for this program represent the different care settings for the management of AF patients in these 35 countries. We have completed recruitment to the registry now, and some 57,000 patients have been included, over 5 sequential cohorts, and eventually we will have between 2 and 8 years of follow-up. The patients entering the first cohort in 2010-11 having the longest follow-up, and those who completed recruitment in July of this year, a minimum of 2 years follow-up until 2018. As I say, the study is being conducted in 35 countries, those represented in blue here. So there are representation in terms of AF patients from the Americas, from Europe, from Asia Pacific, and regrettably, but still a small representation from Africa and the Middle East. Now, the Garfield registry, I think, is an important potential contribution to our understanding about the burden and the management of atrial fibrillation. It's, of course, quite different from the vitally important and foundation-setting randomized phase 3 clinical trials that we've seen in the last few years. We have been trying to collect data from patients who are often excluded from the clinical trials, but who present into routine clinical practice in the different care environments, specialist clinical practice, general medical practice in hospital, and in primary care. And to try and do this in a prospective fashion. Many registries that also make a hugely important contribution to our understanding of the burden of disease collect prevalent patients and data retrospectively. What we've tried to do in Garfield is to try and identify patients within 6 weeks of presentation to the clinical facility with newly diagnosed atrial fibrillation, and then follow those patients prospectively for a minimum of 2 years. And that, we hope, will help us understand not only over the longer term and medium term the burden of disease, but also the early burden associated with newly diagnosed atrial fibrillation. We've also tried to develop a methodology that puts particular emphasis on data quality and audit. Registries, of course, are very large and are not usually subjected to the same data management strategies as randomized trials. But in the Garfield registry, we've organized for 20% of source data to be audited across the entire program for the 5 cohorts. And what we've found in a data audit exercise conducted by Professor Fox and Professor Bernard Gersh on behalf of the steering committee is that about 96% concordance between data in the patient's core notes and clinical records and that entered into the registry using this 20% audit strategy. And that is quite impressive for a registry. Now, today we're going to focus on data from the registry as it currently stands. Of this 57,000 patients, 52,000 are the prospective, newly diagnosed and followed patients. Originally, as part of the first cohort, we took 5,000 retrospective patients as well. They're not included in these analyses. And that was to help us understand how entering centres into a registry may or may not change the way they practice clinically, and to provide us insights into the difference between prospective and retrospective patients. But the data you will see today is on our prospective population of patients. Now, earlier this year, Professor Basson, on behalf of the steering committee, published the first important outcomes from our registry, 2-year outcomes in some 17,000 prospectively followed patients in the first 2 cohorts of the Garfield registry. And what he was able to demonstrate was that there is a very early burden of disease, that the risk of death, the risk of stroke, and the risk of major bleeding in that first 2-year period, of course, was important across every 4-month time period in that 2 years. But the greatest burden, the greatest risk ratio, if I may put it that way, for death, stroke, and bleeding was in the first 4 months after presentation with atrial fibrillation. That's something we've been able to establish because we take patients so early in the natural history of their disease after diagnosis, and therefore can concentrate on the early as well as the later events, where registries that include a time window of 3, 6, or 12 months after diagnosis of AF may miss that early burden in their analysis. What was striking in that 2-year outcomes analysis was the important impact that anticoagulation had on reducing mortality, a 35% lower risk of death in those anticoagulated in the registry compared to patients not anticoagulated, I should say, in the Garfield registry. That entry is based upon the investigator's view that the patient has a risk for stroke, not calculation of the CHADS-VASc, for instance, and also that patients are entered irrespective of treatment intervention. So some patients are anticoagulated, some just receive antiplatelet therapy, and interestingly, an important proportion of patients with newly diagnosed AF considered at stroke risk receive no form of intervention when they enter the registry, according to their clinicians supervising their therapy. Now, what is striking is that the most common causes of death in the registry are causes that are not necessarily associated traditionally with a benefit in terms of their reduction through the use of anticoagulation. Striking was, for instance, that less than 10% of all deaths in that first 2-year period were due to stroke. So there's a lot to think about as we try and understand the burden of disease in newly diagnosed atrial fibrillation. I'm now going to call upon Professor John Cam, who's going to talk to us about understanding better the risk of outcomes in patients with atrial fibrillation data from the registry. Thank you very much indeed.
Thank you, AJ. Good morning, everybody. You can see that my presentation is about the risk of outcomes in patients with atrial fibrillation. And this, of course, is relevant because it is the risk of the outcome of stroke and mortality which is assessed in order to decide whether a patient should be anticoagulated. I'm sure that you all know that yesterday the ESC issued new guidelines on the management of patients with atrial fibrillation. They were published in the EHJ the day before that. And these guidelines have made numerous changes to the management, but one of the most important is that they have changed the category of patients that are suitable for consideration for anticoagulation and for firm recommendation for anticoagulation. Let me show you what the current situation is. This is the 2016 guideline, just a few days old. Now, the guideline uses a risk scoring scheme, which is called CHADS-VASc, which I think you all know very well. Importantly, this contains most of the comorbidities which are known to increase the risk of stroke. It also has a category for female gender. We can see that the CHADS-VASc score of 0 to 1, 0 in men and 1 in women, does not merit anticoagulation according to the guidelines. On the other hand, a score of 1 in men and 2 in women means that the patient should be considered for anticoagulation. In other words, not all of them will require anticoagulation, but some of the more severe patients within these categories should be anticoagulated. And then a firm recommendation for anticoagulation, implying that all such patients should be anticoagulated unless there is a specific contraindication, is given for male patients with a CHADS-VASc score of 2 or more and female patients with a CHADS-VASc score of 3 or more. Now, we also have within the Garfield AF registry a categorization of what we call low-risk patients, which is the two groups on the left, in other words, that do not merit and consider, and we have a high-risk category, which happens to be the same as the new guidelines, in other words, men with a score of 2 or more and women with a score of 3 or more. Now, the important change in the guideline is that women with a CHADS-VASc score of 2 were previously recommended for anticoagulation. They are now only considered for anticoagulation. Now, you can see that the risk obviously increases as you go from left to right. And I'm now going to show you all the categories lined up from top to bottom. And these categories are divided according to what guidelines say. So if we look at these, we can see the do not anticoagulate at the top, and right at the bottom we can see recommend anticoagulation according to the ESC guidelines 2016 and the Garfield high-risk category. In the middle, we see a range of risk categories with lower CHADS-VASc scores, different often in men and women. And you can see how these scores have been used by various professional societies to indicate consideration or recommendation for anticoagulation. Now, what I want to do now is to go back to the left to right format, with on the left having the very low risk and on the right having the high risk category according to guideline specifications. So now we have on the left the do not anticoagulate, and on the right we have the recommend for anticoagulation. In other words, most patients should be anticoagulated. Now, the first thing I think we can see is that these very low risk candidates are anticoagulated in about 45% of cases. Now, this is not all mismanagement because there are other risk factors other than the CHADS-VASc score, but by no means do they account for 45% who should be anticoagulated. So this is a rather excessive degree of anticoagulation. It's divided according to the various anticoagulants that's used, but I would like to emphasize merely that it's a high rate of anticoagulation in a group that the guidelines say do not anticoagulate. And then at the very right, you'll see two high-risk groups. These are the recommendations for anticoagulation in 2012 guidelines and in the 2016 guidelines. And here you can see that rather disappointingly, only about 65% of these patients anticoagulated. So although there's a huge range going from do not anticoagulate to a firm recommendation for anticoagulation, clearly it's not making an enormous impact in what physicians are doing. Now you can see that these patients are anticoagulated between a range of 40 and perhaps 65%. Now I'd like to examine what the outcomes are in patients who are anticoagulated and are not anticoagulated in the Garfield AF registry. And this next slide shows two outcomes. On the left is the stroke and systemic embolus outcome, and on the right, the 1-year all-cause mortality outcome. Now you can see that the low-risk category, on the extreme left, there are actually more strokes and systemic emboli in the group that are anticoagulated than the group that are not, reinforcing the general concept that there is some hazard with anticoagulation, and we should try and restrict it to patients who can really benefit from the anticoagulation. On the other hand, you can see on the right, both the 2012 and the 2016 recommendation group, that stroke and systemic embolism is in the first place very much higher because, of course, they have this increased risk, and anticoagulation, the blue columns, show this reduction of about 35 to 40% in the stroke and systemic embolism. On the right, we can see exactly the same findings for mortality. Mortality is uninfluenced by anticoagulation in all of the low-risk groups. But in the two groups on the right, you can see this major reduction that A.J. Kekar talked about before in patients' mortality when they are anticoagulated. Now, importantly, there is one group that changed in the guidelines, and that is the group which is third from the left. And this is a group of women who have a CHA2DS2-VASc score of 2. And you can see that with stroke and systemic embolism, it's an intermediate rate approaching about 1% per annum, which technically justifies anticoagulation, but you can see it made little difference in the Garfield AF registry to stroke or systemic embolism, and it's made no difference to mortality. Now, those are two outcomes which should be beneficial from therapeutic intervention. But we realize that giving an anticoagulant can also have a downside. Of course, we can have hemorrhage. And I'd like to show you what happened in these risk groups as far as hemorrhage is concerned. You can see on the right the groups that should be anticoagulated, firm recommendation, that hemorrhage is increased. But that increase in hemorrhage is at most doubled, less than doubled when you anticoagulate the patient. And remember, we're getting a major reduction in stroke and systemic embolism. But on the left, all these low-risk groups, you can see that the rate of hemorrhage in anticoagulated versus non-anticoagulated patients is increased 3 or 4 times. So lots of hazard, and as I showed you before, not much benefit. But there are, within these categories, some patients, a large number of patients, who will have stroke and systemic embolism, and we need to be able to better identify them. So my conclusions are just 3, that the updated ESC guidelines have clearly shifted in proportion to the real-world data of how the anticoagulants are used and who they're used in, that some patients are being unnecessarily anticoagulated, and that includes, to some extent, the CHA2DS2-VASc score of 2 in women. And thirdly, that we need specifically to find better scoring schemes or better ways of identifying patients at risk in these rather lower risk categories in order to justify anticoagulation. Thank you very much.
Thank you, John. So now we'll move on to Keith Fox, who's going to talk about the performance of a new score derived from the Garfield AF registry.
Thank you very much, AJ. So you might sigh when you see this and say, do we really need another risk score? Everybody's just got used to CHADS VASC. Well, I hope to convince you that actually we do. And why is this? First of all, let me give you some background and context. Everybody knows that the role of anticoagulation is increasingly recognized, and the proportion of people being anticoagulated with some form of anticoagulation is rising. And these are the data that you can see, rising from 57% in about 2010-11 to about 71%. And within that, obviously, there is a proportion treated with NOACs. Now, leading on from what John Cam has been discussing, here's the real crunch. 28% of those with a CHADS VASC of 2 or more receive no anticoagulation. Now, some of those may be for good reasons, but I would challenge whether they're all for good reasons. And then on the left-hand side of this curve, you can see that 51% of low-risk patients are being treated with an anticoagulant. Is that really justified? Some may be. So I propose to you that what we need is the development of a more accurate and user-friendly method for stratifying patients, one that the clinician can use very readily. And we've just been presenting this at the registry hotline this morning. And this differs from things like CHADS VASC because this is an electronic system that can be resident in the electronic patient record, so automatically produce the risk score. And I propose that one of the challenges we face is that clinicians have 2 different tasks. They have to derive at the moment a risk score separate from what's in the record, and perhaps look at risk factors for bleeding separately. If we could have one integrated score that conveyed information on mortality, stroke risk, and bleeding, that may help to inform clinician decision. So this is a computer-generated, in other words, machine learning. This is behind the front face that would look simple. It's actually very sophisticated. You can't use the old-fashioned multivariate approaches to risk prediction because they have a number of biases. In other words, if you add risk factors, the ones that you add last have the least influence. So they're now, with the help of our colleagues from Duke University, some very smart approaches. And this is what's called coalescent regression. It means that you'd make no assumptions about relatedness of the individual factors when you derive the independent predictors. So there's no bias in the system. It's more accurate because it's continuous and there's no bias. And this is not an integer system, which is either binary yes or no. This is looking at the continuous risk. So behind the simple face of the score is some very sophisticated computer analysis. And the models were trained on 3 different components: all-cause mortality, ischemic stroke thromboembolism, and hemorrhagic stroke major bleeding. And then it was compared with CHADS VASC. And this is specifically the bottom line of what we were presenting this morning. On the right-hand side, I'm showing you the performance of the CHADS VASC score in individuals who are low risk. A C statistic of 0.56, 0.56, and 0.57. And as we all know, flipping a coin would give us a C statistic of 0.5. So frankly, this is not great. Differentiating low risk with our current tools like CHADS VASC is marginally better than the play of chance. That's pretty worrying. In the left hand of these columns, you can see the Garfield score, C statistic 0.72, 0.62, 0.72. And I'm not showing you the data, but actually this performed better even than the Hasbled score, even though it's an integrated score. So let me show you the simple version. If any clinician wants to use this, there's a web-based version that the clinician can just enter the key parameters that convey most of the risk. And then I'm showing you this for bleeding, but it could be for stroke, it could be for mortality. And here's an example for a US patient, aged 89, with a history of heart failure and renal dysfunction. Please note that renal dysfunction is a key predictor, and it doesn't appear in the current risk predictors. And you can see that this individual would have a 20% risk of major bleed within a year. And I would suggest that this might help to inform decision-making. The other end of the scale, there may well be people with very low risks that it helps to inform. So my conclusions are these: that the Garfield score was superior to Chad's VASC, and obviously this is relevant to the new ESC guideline update. It predicts stroke and systemic embolism. It predicts cardiovascular mortality and bleeding. It was tested independently in an entirely different data set, Orbit AF, and it performed equally well in Orbit AF. And I would argue that either integrated into our electronic record or the web-based system has the potential to help inform clinicians so that he or she may make a more informed decision on who to anticoagulate and who not to anticoagulate. Thank you very much.
Thank you, Keith. Thank you very much. We'll now move on to Professor Jean-Pierre Basson, who's going to look at comorbidity in early events in newly diagnosed atrial fibrillation patients.
Thank you, AJ. Good morning, everybody. So this is my privilege to report about comorbidities and early events in newly diagnosed patients with newly diagnosed atrial fibrillation patients. Just a couple of slides, but reminders. We know from earlier registries and also from Garfield registry that the new onset atrial fibrillation carries a risk of death, early death, and stroke. The excess of death of patients with atrial fibrillation compared to patients without is in the range, depending on the registries, between 50 and 90%. So serious increase in the risk of death. And we have known for long, that the stroke is 5-fold higher in rate in patients with atrial fibrillation compared to those without atrial fibrillation. And AJ referred to this just a few minutes ago. Here, I just remind you what the impact of atrial fibrillation is on the outcome. And here we are speaking about new onset of atrial fibrillation, the beginning of the disease. But look at the impact after 2-year follow-up. And generally speaking, when you ask people, physicians, even cardiologists, what is the highest risk incurred by the presence of new onset of atrial fibrillation, they will answer stroke. And this is not true. The highest risk for the patient is mortality. And you see that the risk of stroke counted as a rate per 100 person years is 3-fold lower compared to all-cause mortality. And major bleeding is 4-fold lower than mortality. So definitely the highest risk for the patient is death. And we have observed, as a reminder to you by AJ, in the first analysis, first outcome analysis of the first 2 cohorts, including up to 17,000 patients plus, that there was an excess of event in all 3 major events within the first 4 months of evolution. This was true for death, 29% increase compared to the rest of the follow-up, in patients with new onset atrial fibrillation, 35% increase in the risk of stroke, and 56% increase in the risk of bleeding. And then we had more granularity in analyzing the phenomenon, and a more recent analysis carried on 28,000 plus patients confirmed the data from the previous analysis on 17,000, but showed that during the first months, the excess of events, at least in terms of all-cause mortality, is even higher. You see here, 60% increase in the risk of death, still an increase at between the interval 2-4 months compared to the rest of the rate of the rest of the follow-up. So very high risk of death and other major events during the very beginning of the evolution, and particularly during the first months. And here, we tried to analyze which were the factors that contributed to this very early risk of death. And there are some here, the list is not limitative. Previous myocardial infarction, yes or no, you see a threefold increase in the risk of death during the first months in patients who have a previous myocardial infarction compared to those who have no previous myocardial infarction. Moderate to severe chronic kidney disease, threefold increase in the risk of death, and again, over and again, chronic kidney disease now appears in the evolution of atrial fibrillation as a major predictor of all major events: death, stroke, and bleeding. Here, it confirmed for early mortality, CKD has a major impact. Previous stroke, threefold increase in the risk of death, early death. Now, at 4 months, it's the same story, but to a lesser extent because we have concentrated first on the first month, and then it's vanishing a little bit. At 4 months, twofold increase in the risk of death in patients with previous MI. At moderate to severe kidney disease, threefold increase. And previous stroke, twofold increase in the risk of death during the first 4 months. After 4 months, it looks as if there is no excess of events compared to the long-term evolution. And this slide is very instructive because it shows you in blue the 1 month causes of death during the 2-year follow-up. Months 1 in blue, months 2 to 4 in red, months 5 to 24 in green, and confirms what we said: early excess of death and cardiovascular death, excess of cardiovascular death during the first months and the following 2 to 4 months for cardiovascular death. And you see on the opposite side of the slide, non-cardiovascular death, what it is. This is malignancy, this is respiratory disease, infection, sepsis. But non-cardiovascular death, there is no excess at all of early non-cardiovascular death compared to cardiovascular death. And here, some of the factors, the variables that affect the outcome, and we spoke already about myocardial infarction, unstable angina. Congestive heart failure is also a major contributor to the early death, as you can see here, sudden cardiovascular death, and ischemic stroke during the first month. So what does this mean? This simply means that, again, patients who are suffering from atrial fibrillation and who have recently been diagnosed with new onset of atrial fibrillation, we capture this patient at the beginning of their evolution. They are at a much higher risk of death, and this risk of death is driven by the comorbidities, mostly by the comorbidities. And this is what the cardiologist should consider now when they take care of these kind of patients. The gut reaction of the cardiologist so far was give anticoagulation. This is right. We have to give anticoagulants to those in need of anticoagulation. That's right, but that's not enough. And we should consider also an aggressive reduction of the risk factors which are involved in this early risk of early risk of mortality. And this is the summary on this slide. Atrial fibrillation might be considered as a trigger and triggering many factors that involve the comorbidities, particularly coronary artery disease, acute condition, heart failure, and we have to take care of all these conditions and treat not only the risk of stroke, but have a comprehensive approach and treat also all comorbidities and risk factors. So to summarize, mortality was higher during the first months and during the first 4 months than the overall rate during the 2-year follow-up. Cardiovascular death seems to be the most important component of early mortality. Mortality in the first month was higher in patients with prior MI, moderate to severe CKD, prior stroke, but not only congestive heart failure as well, than in patients without these comorbidities. And comorbidities may account for some of the excess of mortality risk, which underlines the importance of an integrated approach, comprehensive approach to the problem. Thank you.
Very much. Now we have the opportunity for some questions, if you would like to put those to my very distinguished colleagues. Are there any questions? Would anyone like to start off? Please. Oh, here's a microphone so everyone else can hear you. Thank you very much.
My name is Angela from Cardiac Rhythm News. This is for Dr. Kam and Dr. Fox. Should physicians now take the CARFIELD score as the priority as opposite to the CHA2DS2-VASc score?
So,
John, why don't you start? Because I might be quite biased.
The CHA2DS2-VASc score is very good at identifying patients at relatively high risk of stroke. It is not good at sorting out the relatively low-risk patients, the 1% per annum stroke rate and less. We know that we can obtain therapeutic advantage down to about 0.7% per annum by using anticoagulation. So we need to try and identify that group of patients. And clearly, the more precise the identification, the larger the stroke rate we would get, and the more valuable as the score would be in identifying the patients who need to be anticoagulated. So we would like the score not only to resolve those patients who should be anticoagulated, but also give strong reassurance that there are groups of patients that do not need anticoagulation. And it's for that reason that we need better scoring schemes. Now, what you've heard Keith say today is that there is a different approach. Instead of simply ticking a few boxes and adding, if you like, somewhat arbitrary values to those boxes, like 1 or 2 scores, and then adding them up for a total, it would be much better to use more precise data and use a computerized system for finding the patients at most risk. And of course, this kind of machine learning that Keith is talking about is not a simple one-step approach. The computer can continue to learn data as it gets more and more information. So we're at a stage now where we're beginning to show clear advantages for the low-risk group by using a machine learning technique. But as we accumulate greater data sets, for example, as we get 2-year data in all our cohorts, and perhaps when integrated into electronic medical records, we can then have the option of all of those data feeding back into the electronic machine learning concept. We can get an extremely accurate appraisal of patients who are at risk. Right now, we can start, but we're waiting for the simple web-based scheme in order to allow that to happen.
Thanks, John. If I can just add a couple of points. Firstly, if we had a perfect risk score with CHA2DS2-VASc, I wouldn't argue for a change. But what we've shown you is that identifying low-risk patients is really not very reliable with CHA2DS2-VASc. Secondly, the practice worldwide does not match the risks of bleeding and the potential benefits of the patient. So either we accept that, or we say, let's have something that's simpler and easier to use that can pop up on the electronic clinical record so that the clinician doesn't have to go and do this separately. And he or she would then be able to automatically bear that in mind when making their decision. So this is the start. This is not the definitive, this is the start. But I think, yes, people will be turning.
Yes, please, over here.
Hi, good morning. Melissa Walton Shirley from the Heart.org Medscape Cardiology. We all know of patients that have not been identified properly and have stroked, even though their label is CHA2DS2-VASc 0 or 1. And I think my personal opinion is that we do not detect diabetes because we don't include a fasting blood sugar or a postprandial blood sugar. So will your future risk scoring include those caveats?
Okay, so that's another really important point. I highlighted the fact that there are a whole series of risk factors that we now include that were not part of CHA2DS2-VASc. And one of the limitations of CHA2DS2-VASc in the apparently low risk is if you've got a C statistic of 0.56, it's marginally better than the play of chance. And for our patients, that's not good enough. We need something better than that. And what are we going to do in the future? We are going to improve the iterations of this, including the addition of biomarkers potentially, to have as accurate a score as we can.
Okay, another question, please. Yes.
Thank you very much. Henry Purcell, British Journal of Cardiology. If I might ask two questions. Will the new integrated risk score system incorporate HAS-BLED type information, or is that to come? And secondly, if a patient has a myocardial infarction, in terms of doing poorly with comorbidity, does it matter a great deal whether there's left ventricular dysfunction or not?
Okay, so both really important points. Dealing with the left ventricular dysfunction, that is assessed separately in the risk score. So in other words, heart failure, because that's a powerful predictor, in addition to the prior risk of ischemic heart disease. Secondly, unfortunately, HAS-BLED is not sufficient. So if you've got one score that gives you a better predictor for bleeding, as well as for stroke risk and for total mortality, I think that's going to be useful. So there's no separate calculation of HAS-BLED. I'm afraid HAS-BLED is limited in its accuracy.
As you know, Henry, the HAS-BLED score was actually eliminated from the ESC guideline this time round.
It doesn't appear.
Scoring schemes were discussed and abandoned, largely because the scoring schemes have led to patients not being anticoagulated when they should be anticoagulated. And physicians are now encouraged simply to identify potentially modifiable risk factors and definitely modifiable risk factors and attend to those as they prescribe anticoagulants.
Okay, another question, please.
Kevin Grogan from, I don't know who I'm with today, Freelance mainly. I was just interested in these figures about the patients receiving anticoagulant treatment for stroke prevention has now gone up from 57% to 71% in the last 5 years. Could you comment on this particularly? And is this a problem that people shouldn't be treated? A lot of them.
John, would you like to take that?
You're quite right that there has been an increase in the proportion of patients who are anticoagulated, but there remain to begin with about 10 to 12% of patients who definitely should be anticoagulated and are not anticoagulated. We're looking into that group to find out why that is. Some of them will have definite contraindications to anticoagulation, but many of them, I think, will not. Then there are a group of patients who still receive aspirin, and that's about at the 20% mark. thus accounting for the 30% or so who are still not anticoagulated. The remainder are anticoagulated, and if we look at the trends over the last 5 or 6 years, we can see that the proportion of patients who should be anticoagulated and are treated with NOAC treatments has increased quite remarkably. VKA treatment has actually fallen, and aspirin monotherapy has fallen. But the not anticoagulated group has not changed. So I think it's a combination of increased education about the need for anticoagulation, the introduction of new anticoagulant drugs which are somewhat safer, easier to use, don't affect lifestyle as much, don't require monitoring, and so on. And that has, to a large extent, supplemented or replaced aspirin therapy and replaced some of the vitamin K antagonist treatment. But on the whole, it's been a very favorable progress from around 50%, 57, whatever it is, to 72% at the present time.
Okay, any further questions? Please.
Davey from Australian Doctor, Cardiology Update, variety of other Australian publications. I'm writing for both GPs and cardiologists. I'm interested, who is prescribing aspirin at the moment? I was talking to a cardiologist this morning, and he said no one prescribes aspirin anymore. So can I assume that it's GPs doing that, or why is aspirin still being used when the general thinking is that it
maybe all of you would like to give your views on that?
I don't think we've made that specific analysis in Garfield, but we do have the data to make that analysis. So what I'm saying is not based on Garfield data, but on my experience. And I would say that hospital cardiologists are certainly not using aspirin monotherapy for stroke prevention in atrial fibrillation. They are using aspirin together with anticoagulants in patients who have specific indications for antiplatelet therapy. So, for example, with unstable angina or post-myocardial infarction, etc. And that's entirely understandable. If you go, however, to the GP level, we know from just a few years ago, very substantial analyses demonstrated that aspirin was actually used more than anticoagulants, for example, in the United Kingdom. In Japan, on the other hand, they completely outlawed the use of aspirin about 6 or 7 years ago in their very early guidelines on how to manage this problem. And aspirin is hardly used at all in Japan. Within the Garfield registry, aspirin has disappeared. It's taking a long time to disappear in the global figures, and we know that many of the poorer countries are using much more aspirin than the economically more well-off countries. So if we look at the classifications of good economies versus middle to poor economies, we find that NOACs have replaced a lot of the aspirin use in the high economies, but not in the low economies.
But I think we still have an educational task, because there's still a misperception that aspirin might be a safer option. And yet the evidence, as we know, shows that the bleeding risk is as high as with anticoagulants, and it is less effective. So I think across all of our countries, we've got an educational task to address that. And I think that it's going to be quite challenging to change some of those preconceptions, but it will need to be done.
Okay, unless Jean-Pierre, you've got anything to comment there?
No.
No. Okay. Any further questions? Okay. If not, I'd like to thank my colleagues for having contributed to this event this morning, having presented some of the evolving and emerging data from the Garfield AF registry. I think what we've seen is that there still remains a substantial burden associated with atrial fibrillation, that we need to do more to understand how that burden represents itself, and how best in addition to interventions to prevent stroke risk, we might be able to improve clinical outcomes through a more holistic approach and greater attention to the management of associated comorbidities in AF patients. We've also heard, I think, during this Congress, with the publication of the new ESC guidelines with regard to atrial fibrillation, a changing view and greater emphasis on trying to better understand how best to serve patients who are considered at low stroke risk in atrial fibrillation, to differentiate those populations, to understand within that group who has high stroke risk, who has a higher bleeding risk. And we've attempted, through the development of this new risk score, to start addressing that question and helping better improve clinical practice in that low risk group. I'd like to thank you all very much for coming this morning and listening to these presentations, and wish you a most enjoyable Congress. Thank you very much indeed.